Hello, everyone. I hope you're all doing well. My name is Rashita, and I'm one of the chair people at SUPTA. Welcome to the sixth week of our teaching series. This week, we are focusing on upper GI surgery, and we're very happy to have you all here with us today. Today, I'm joined by Henry, who will guide you through upper GI cancers. Henry is a fourth year from the Brighton and Sussex Medical School. To make the session as engaging as possible, we'll be releasing polls throughout the session. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll address them at the end of the session. We'll also share a feedback form at the end. If you complete this, you'll receive a certificate of attendance and exclusive discount codes to Teach Me Surgery and pass the MRCS. This session is being recorded, and the recording and the slides will be shared on our Meta page as well as our website a couple hours after the session. So be sure to keep an eye out for that. As you may know, we have launched our very own learning portal, which is hosted on our website. Through this learning portal, you'll get access to practice questions, session recordings, and revision material. As a bonus, all members will get a discount code to get 10% off the Geeky Medics anatomy flashcards, surgical flashcards, and knowledge bundle. Membership is completely free, so be sure to head on to our website after the session to explore this. We also have an exciting opportunity for all of our attendees. Two people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we will provide. The more sessions you attend live, the higher your chances of winning, so be sure to stay until the end of today's session and attend as many of our other sessions. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Henry.
Hi guys, I'm Henry Schmid. As you see, thank you very much for the introduction. So today I'm going to be talking about upper GI cancers. There's a lot to go through here today, so I hope you're all happy to stick with me. These are a couple of learning objectives. So without further ado, let's get on to it. So let's start with the anatomy of the upper GI tract. Don't really have to go through this in much detail, as you guys should probably notice at this stage. I've put a little query in the corner saying sad pucker. Does anyone know what this might be? If there's anyone putting it in the chat, and I hope you all know that it's all the retroperitoneal organs. So that's the supraadrenal, the aorta, the duodenum, the pancreas, the ureters, the colon, the kidney, the esophagus, and the rectum. Now we're going on to the anatomy of the esophagus. So you could just broken it down to the cervical, thoracic, and abdominal parts. And now we're going to talk about the blood supply to the esophagus. So the cervical esophagus, so we're talking about this upper part here, we're going to be supplied by the inferior thyroid arteries. So these arteries here coming off from the subclavian. Then the thoracic esophagus here in the middle is going to be supplied by the thoracic aorta and the bronchial arteries. Then the abdominal esophagus, which is branching into the gastric part, is going to be supplied by the left gastric artery. And then similar with the venous drainage, you've got the cervical esophagus, which will be drained by the inferior thyroid veins, which are here again, coming off the thoracical. The thoracic esophagus, which are draining into the esophageal veins, and then the abdominal esophagus, which is going to be draining into the left gastric. And then similar with the lymph drainage, so this is really important when we think about where these cancers might be metastasizing, especially esophageal cancers. So you've got the cervical esophagus, which is going to be draining into the deep cervical lymph nodes, the thoracic esophagus, which will be draining into the posterior mediastinal lymph nodes, and the abdominal esophagus down here, it's going to be draining into the left gastric lymph nodes. And so some places we'd be thinking of where it's most likely for esophageal cancers to spread and metastasize, we're probably thinking that, especially if it's down in the lower abdomen, we're going to be thinking it's draining into the liver and then superiorly maybe into the lungs as well. So I've also been asked to discuss the stages of swallowing. So these are broken down into three phases. So the oral phase, which is a voluntary phase, the pharyngeal phase was involuntary, and the esophageal phase, again, which is involuntary. And so you're going to be, in your voluntary phase, you're going to be eating your food. The food's going to be hitting your hard palate, which is here at the back of your mouth. And then this is going to trigger your hypoglossal nerve to enact swallowing. Then the bolus is going to enter the oropharynx, which is back here, just behind your tongue. And it's going to trigger the swallow reflex. It's really important that you're going to be closing off your epiglottis here. And this is done by cranial nerve 10 as well. And then the involuntary phase, in the esophageal phase, so going down the esophagus into your stomach, your esophageal sphincter is going to relax, and the bolus is going to enter the esophagus, and then through primary peristalsis, this bolus is going to be pushed down, and then secondary peristalsis is going to occur if any remaining food is there. Next, moving on to the histology of the esophagus. So this is really important when we're thinking about which cancers are in which part of the esophagus and why. So the upper is primarily made of, or entirely made of skeletal muscle. The middle is made of mixed smooth and skeletal muscle, and then the lower extremities are made of entirely smooth muscle, really, portions. So now moving on to the cancer locations and the types of cancer seeing in each part. So the upper third, like we said, we're talking about this smooth skeletal muscle. We're going to see them, these are going to probably differentiate into squamous cell carcinomas then. The middle third is a mixture of both, but we mostly will see squamous cell carcinomas. And then again, in the lower third, because we've got that muscular glandular cells, we're going to see adenocarcinoma. Next, moving on to the tumor classifications. So this is really important when we're thinking about how to manage certain cancers. So we're going to think about the tumor depth, so T, the N for lymph node involvement, and the M for distant metastases. And this is broken down into quite an extensive list of different types of Ts. So you've got the Ts where it's very small. The cancer's not really invading any of the further tissues. You've got T2, which is invading the muscular propria, which is that further muscular tissue, really. And T3 is the adventitia. And then the 4 is moving on to adjacent structures. And the nodes, we're seeing N0 has got no lymph node metastases, N1, 1 or 2, N2, 3 or 6, and then 3 greater than 7. And the metastases are either present or not present. And again, when we're talking about esophageal cancer, we're talking usually the liver. So I think we'll move on to our first poll question today. I don't know if you guys can see that poll question.
So we just had some responses. 85% have gone with the liver and 12% have gone with the peritoneum.
Yeah, you'll be absolutely right if you're going for the liver. Like I said before, it's the most common site of drainage for metastases for esophageal cancers. It's got a rich vascular supply, and when we're thinking about, especially in the lower esophagus, when you're eating that food, it's going to be going into the portal veins and then be draining into the liver. Other common sites, like I said, are the lungs, bones, and also, interestingly enough, adrenal glands, but the liver is the most common place. Then we're looking at risk factors. So these can be split into, as I say, with the 2 different types of cancers and the 2 different parts of the body, 2 different parts of the esophagus, we're going to be seeing this. So we've got squamous cell carcinomas and the different risk factors we see for that, and adenocarcinoma and the different types of risk factors we'll be seeing for those types of cancers. So again, this is just the cervical part and the thoracic part. We're going to be looking at for squamous cell carcinoma. And we'll be seeing smoking, as you can imagine, smoking, breathing in that hot air or the tobacco and the tar, damaging all your esophagus, as well with excessive alcohol consumption, especially when we've got those higher alcohols, so higher percentage alcohols like vodka, whiskey, etc. And then also you've got things like hot beverages as well, and HPV, interestingly enough. So you see that a lot. And also another risk factor for cervical cancer. And squamous cell carcinoma is probably the most common cancer you're going to be seeing when we're talking about esophageal cancers. And then adenocarcinoma, so we're talking about the lower part of the esophagus, going into the abdomen and the lower thoracics. So here we're going to be seeing GORD as a risk factor, Barrett's esophagus again, obesity. Smoking can be, but smoking is a risk factor for most things these days. Male gender, interestingly enough, However, interesting enough, we've got H. pylori, which is a protective here, but it will be a risk factor for another cancer we'll be moving on to soon. And we'll see this more in Western countries, particularly like Europe and North America. We've got the high fatty diets, we've got more people with obesity. And these are going to be common symptoms you'll be seeing. So you'll be seeing lots of maybe regurgitation, persistent coughs, difficult pain swallowing, weight loss, heartburn. But these obviously can be quite late signs. So we can break down esophageal cancer symptoms into early and late signs just to help your presentation and understand with your differentials as well. So your early symptoms, we're going to be talking about dysphagia. It's going to be starting with your solids, then it's going to be moving down into like liquids as you go further through and the cancer gets bigger. Adonophagia, so there's going to be your difficulty swallowing again, but further down, be feeling of chest pain or heartburn, and again with retrosternal discomfort and mild chest pains or GORD-like symptoms. And then your late signs is when we're talking about like maybe difficulty swallowing fluids. This suggests that there's over greater than 50% luminal obstruction, and then also other common cancer signs such as unintentional weight loss, regurgitation of food, and then you also maybe see like hoarseness as well, hiccups, hematemesis as well, when we're really getting down the line. And there's common sites of metastases in the lymph nodes. We see Virchow's node, left supraclavicular node. This will be palpable, and this is for most gastric cancers. If you feel a palpable Virchow's node, it suggests that there's been lymph node spread of the cancer. You're going to see hepatomegaly and jaundice if you're going to see liver metastases, and also you might see bone pain if you've got bone metastases. There are some diagnostic tools, so we're going to be using endoscopy, as with most of our upper GI cancers that we're going to be seeing. We want to visualize what's going on really in the mouth and in the throat and in the digestive tract. Then we're going to be moving on to CT scans as well, and it's going to be sending like where the primary tumor is, maybe if there's any lymph node or any metastases. You can use a PET scan if you think that the cancer spread for other parts of the body. You can use endoscopic ultrasound as well. This will be looking to see if you think that the cancer maybe is borderline between T2 and T3, and then you're defining if you want to do a radical surgery or a minor surgery as such. And then a staging laparoscopy. This is similar to an endoscopy. So the curative management, most curative managements are in cancers surgery, really. And that's getting rid of the cancer, really. So surgical approaches, and is usually used for locally resectable diseases, so stages 1 to 3. And then we're going to be using, you can also do endoscopic mucosal resections. These are for really small tumors, very early stages. And we can know that it's not gone through the muscular propria, and we can just get rid of it easily. And then also adjuvant therapies as well. So a lot of time in the cancer, we won't, in surgery, especially oncosurgery, we won't just be doing cancer if there's surgery, won't be just be doing surgery if there's cancer present. We'll also be doing chemotherapy to try and reduce the size of the cancer and make the surgery easier. And then we'll also have palliative measures as well. So palliative chemotherapy, just to extend people's lives, really. And then the use of NG and PEG feeding, or TPN, especially in severe cases. And of course, we're going to be doing some pain management as well. These are not comfortable cancers to have, and they can cause a lot of psychological trauma to these patients as well. So there's a lot of support and a big MDT support. I think we'll go into our second poll question, actually.
So we have 83% going with C, that is upper GI endoscopy with biopsy.
Yeah, and you'd be absolutely right there. So why not the other options? I mean, barium swallow is not really used for, it's used more for motility disorders. Esophageal manometry, that's used for again, motility disorders like achalasia, CT chest abdomen can be used, but it's more used for staging rather than initial diagnosis and 24-hour pH monitoring. I'll let you guys think about when you would use a 24-hour pH monitoring, because it's a good one. And if anyone can put it in the chat, just let me know. So moving on to surgical management, you've got Ivan Lewis. So there's two main surgeries that we'll be going through. So Ivan Lewis, and then we'll go on to the next one as well. This is a two-stage approach, and this is used for mid to distal cancers. So you can see here, there's a mid cancer here on the esophagus, and we're going to try and resect that. But we're leaving this big gap on the esophagus. What we're going to do is we're going to transcend the stomach up. I'm going to meet it to the esophagus, the leftover esophagus, essentially. And it's good. It works. It's better than a lymphadenectomy. But like we say, it's higher risk of anastomotic leak in the chest, which can be fatal. And so this is why sometimes if we've got higher tumors, we'll be opting for something called a McNewn esophageectomy. This is a 3-stage approach. So it's very similar to an Ivan Lewis. We're going to be making incisions in the laparoscopic incision and then a transthoracic incision as well. And we're going to be doing an esophageal resection, getting rid of the cancer and the tumor. And then we're going to do a cervical anastomosis as well. But we're going to be bringing this up higher, essentially removing the whole of the esophagus. And it has less risk of leaks, but there's a higher risk of anastomotic strictures. This would have been a nice one to have an interactive session with, but so post-op complications with most GAs, you're going to be having pneumonias. People sat there in the having surgery, having tubes down their throats, in cold rooms, not moving much, not breathing, expanding their lungs to full capacity. Pneumonia is going to be a big one. Like I said before, anastomotic leaks, especially with the McNewn procedures and Ivan Lewis, we don't want those to be happening. They can be really fatal. Ischemia, recurrent laryngeal nerve injury, and you'd be having maybe hoarseness, a risk of aspiration as well because of recurrent laryngeal involved in both of those. Formations of strictures, these are common complications you get with any surgery. But also you have something specific to cancer, to gastric surgeries. You're having maybe dumping syndrome. This is where you have rapid gastric emptying, which can cause hypoglycemia, dizziness, diarrhea, and imbalances in your electrolytes as well. And you can see here that prognosis really for esophageal cancers is not very good if we're getting down to that 4th stage. Particularly with any metastases, distant metastases, we're talking about as less than 5% 5-year survival. Squamous cell carcinoma is less survival in the West because it's later presentation, and then adenocarcinoma has got more common, and the prognosis again depends on the early detection and the surgical resectability. I think we'll move on to our 3rd poll question.
So we have 75% going with B, so that's T2N0M0, and the rest are going with C, that is T2N1M0.
Yeah, if you went for T2, you'd be right. I mean, it states in the question, it's the only one that says in the question that the muscular propria is involved. So that's again, your T2. If it went through into the adventitia, then we're talking about T3. And obviously it's not N0 because there was no lymph node involvement mentioned as well, or distant metastases as well. So M0. Well done. The stomach anatomy. So what we can see here on the right is a cadaveric picture of a stomach. I quite like doing teaching of cadaveric pictures. If you do ever have a cadaveric picture book, do start learning from it. It's the best way to start learning your anatomy. It's the most lifelike because this is how it looks like in real life. It's all a bit of a mess, and none of the colours are quite so distinct. But you can see here 15 is the stomach. And then on the left-hand picture, you can see here, this is what the anatomy of the stomach looks like. We've got the cardiac part, which is where the cardiac sphincter lies. You've got the fundus of the stomach, body, and then you've got the pyloric going into the pylorus. So the arterial supply of the stomach is coming off, most of it, all of it is coming off the celiac artery, and it's coming straight out of the T12 off the aorta, the celiac artery, and it's broken down into your left gastric, which is going to be its own supply. That's going to be supplying the lesser curvature and the celiac and the esophageal part as well, the lower esophagus. You've also got the splenic artery, which is going to be providing its short gastric and your gastroeplochial, if I can pronounce that correctly. And then you've got on the right hand side, you've got the common hepatic breaking into the gastroduodenal, the gastroeplochial right side, and then also into your right gastric as well. And then the venous drainage as well is, this is all going into your portal vein or your splenic vein, or your superior mesenteric, and into superior mesenteric, into your portal vein and into your liver, but it's got to be filtered and drained. And you can probably guess where most of your metastases are going to be going to. That structure there where your portal vein will be entering. And yeah, if you guess right, it'll be your liver. Drainage as well. All these lymph nodes around the lesser curvature, the greater curvature, and the fundus. These are really complicated. It's probably not the best thing to go into in detail, but if you do want to learn them, on the left. And you can break them down into the drainage into segments 1, 2, 3, and 4. So gastric cancer is the 5th most common cancer in the worldwide and the 4th leading cause of cancer-related deaths. So they're really high up there in terms of prevalence and also mortality risk. High prevalence in East Asian countries. This is probably due to their salt-preserving foods. They have a lot of fermented foods and salt-fermented foods, and a lot of raw food as well. When we're talking about raw foods, we're talking about a greater risk of Helicobacter pylori as well, which is a risk for your duodenal ulcers and your gastric ulcers, which would be a risk for gastric cancer. I mean, there's a lower incidence in Western countries, but we're seeing rises of all cancers really across the Western world, and this is linked to really obesity and GORD as well. It's more common in men, and this is probably mainly because women are maybe going and getting themselves checked out if they've got infections, and getting rid of the H. pylori, rather than men who tend to just leave things till late. And yeah, again, another statement about H. pylori being really important and vital to the epidemiology of this disease. So 95%, we're talking about the stomach, is those columnar cells, going to be those secreting cells. That's going to be your adenocarcinomas then. It can be broken down into the proximal cancers, linked to Barrett's esophagus, going into the lower part of the esophagus, and then also your distal cancers, which are not your non-cardia, so your non-top of the stomach. And these are associated with your H. pylori, your smoking, and your high salt diets as well. There's other types as well. These are less so common. As you say, we've got 95% adenocarcinoma. So you've got H. pylori related ones. You see these 117 positive ones as well, and your neuroendocrine tumors as well. This image hasn't come out quite as well as I hoped it would be, but these are some of the risk factors you're going to be looking at again. So I've already spoken about some of the risk factors, such as like smoking, your diet, your obesity, your H. pylori status as well. But we've also got other ones, such as like pernicious anemia as well, and long-term stomach inflammation. So you're talking about your celiac diseases there. Your symptoms of gastric cancers, these are less so easily broken down into early and late signs, just because of the presentation, not talking about swallowing or anything like that. We're not talking about progressive problems. But like, you've obviously got your unexplained weight loss down there, which is a late sign of all cancers. But then other ones might be loss of appetite. You might be feeling full quicker after meals. You might have like heartburn, indigestion, you might have pain as well, and also nausea and vomiting. And if it's containing blood, it's a strong risk factor or high likelihood of maybe of a gastroduodenal ulcer, or it could be also cancer. So it's important to rule out these differentials when you're taking histories from patients. Obviously, you should be always thinking about cancer. Does the patient have cancer in front of you? Because it's really important to rule out, and they want to be looking for that, especially in your OSCEs and your GP OSCEs. So peptide ulcer disease, similar symptoms, but these are often relieved by food and antacids. Your gastritis, you'd be having fevers, and also you probably would have eaten something in a really acute course, talking about something maybe like you ate something 5 hours ago and you've got these symptoms of diarrhea, vomiting, etc. Your GORD, this is really risk factors like drinking, smoking, obesity, gastric polyps, similar. These are like your H. pylori risk factors, and you're going to be maybe seeing that coffee ground staining vomit if it's a gastric cancer, duodenal cancer, and you might be seeing fresh blood as an esophageal polyp. And then your pancreatic, you have to always rule out pancreatic cancer, and we'll get onto that more as well later. So again, investigations, you want to be starting with maybe your bloods. So maybe checking for anemia, especially if this patient's bleeding. And that'll be the main thing you'll be looking for, really. You could be doing biopsies as well, and an OGD as well. So as again with esophageal cancers, you'll be looking down through in their mouth and their stomach and see what's going on. This is the gold standard. This is really what you're going to be, the bread and butter what you're going to be using. And it also can be used for your H. pylori infections. And this one you could be doing your rapid urase or your pH testing as well. You could be doing your imaging as well, CT scan if you think it's spread to other parts of the body, and then your laparoscopy as well. So again, curative management, you can guess what this probably is: surgery, your chemotherapy, your neoadjuvant chemotherapy. But we're going to be wanting to resect that, really, getting rid of that tumor. And then your palliative is your radiotherapy, chemotherapy, and then stenting. So types of surgical approaches, we can get rid of the whole stomach. And this is what we're going to be doing for like proximal cancers. There's no point in really keeping it. We don't know if it's spread around the whole stomach. We're just going to get rid of all of it. And then subtotal gastrectomies for your more distal cancers. And of course, with any GI cancers, you're going to be getting vitamin deficiencies. You might be getting dumping syndrome. You might be getting all sorts of gut issues, especially when you go on to further and you may be having to go through a total gastrectomy through the formation of a Roux-en-Y. If you do get a chance to go see one of these in theatre, they're absolutely spectacular and they take a long time. I would really recommend you go see one of these. So what you're going to be doing is you're going to be getting rid of the stomach. You don't, because obviously it's got the tumor in it. You're going to get the jejunum's divided, and we're going to get a segment of it around about 40 to 75 centimeters long. And this is going to be called the Roux limb. And this is going to be brought up to the remaining esophagus. So you can see stomach's removed, and then this is the Roux limb. And we're going to attach that to the esophagus. We're going to leave the duodenum where it is. And this is going to form onto and act as to give your body all its pancreatic and your bile and any other exocrine hormones it's going to need to digest the food. And then, like I said, the final part's going to be this part of the jejunum anastomosed to the remaining jejunum. So your stomach is your jejunum now. There's also other techniques. So we're talking about like these are T1A tumors or T1 tumors, tumors that haven't invaded that muscular propria. We're going to be similar to what you do with a colonic polyp. You're going to be pumping fluid behind where the cancer is, lifting that off that cancer and the tumor off the surface, and then you're going to resect it. So now we can do the fourth poll question.
Okay, so we have 66% going with C, which is gastric outlet obstruction, and 33% going with gastroparesis.
Okay. So there's a little bit more of a divide on this one. So for gastric cancers, especially in antrum, these can lead to obstruction of the gastric outlet. These are going to be leading to really gastric outlet obstructions, like you say. The clinical features you're going to see are like nausea, early satiety, non-bilious vomiting, maybe a succussion splosh. And this is I've never seen it in practice. I mean, if you do put in the comments if you have seen it in practice, but it's essentially a sloshing sound you're going to be hearing on auscultation, and this is due to retained gastric contents as well. It's not peptic ulcer disease because though it can cause gastric outlet obstruction, the patient has a history of gastric cancer. Achalasia is a motility disorder in the lower esophagus. And then small bowel obstruction is more likely from adhesions or hernias. And then gastroparesis, so this is delayed gastric emptying, but it's got no true mechanical obstructions, really. Next, moving on to our final bit, pancreatic cancers. So the pancreas is this retroperitoneal organ. This could be linked with all your exocrine hormones, providing all your bile, or your insulin, or your rest of your hormones, your fluids that you're going to need to digesting food. And it's found, the head is found at L1 vertebrae. And it's just hidden here behind the stomach. And because it's hidden here behind the stomach, the presentation of these are very late. You don't really get signs often in the early stages. It's just a really horrible, nasty cancer. And I was told once by a general surgeon that only nice people get pancreatic cancers. So that's one reason not to be nice, maybe. But yeah, they're just a horrible, horrible cancer. So the arterial supply to the pancreas. So you've got the splenic artery. Again, this is coming off the celiac trunk. And it's going to be then feeding the body and the tail of the pancreas. You've got the gastroduodenal artery. This is from the comic-hepatic artery. That's going to be supplying the head. Then you've got the superior mesenteric artery. And this is going to be supplying the head and the inferior pancreatic duodenal artery. The venous supply. So you've got drainage from the superior pancreatic duodenal veins and the inferior pancreatic duodenal veins. And these are going to be going into the superior mesenteric vein and into then your portal vein. And the body and the tail, these are drained by the pancreatic veins again into the superior mesenteric. And again, you can probably guess where the most common site of metastases would be. And yes, you'd be right if it's saying the liver. Again, all these lymph nodes that are very, very difficult to visualize and very difficult to see, even when you're under surgery. And the head of the pancreas, this drains very close to duodenum, and the celiac and superior mesenteric lymph nodes. The body and the tail drain also into celiac and splenic lymph nodes. And they all end up in the sternochyli, which is the main lymph node, which can be draining into the thoracic duct. So there's not many cases annually each year, about 30 people a day, but you can really see that the survival ratio of people with pancreatic cancers is really poor. Most people presenting late. Yeah, and it's for such a small amount of number of cases, it's the 5th leading cause of cancer deaths in the country. So different types of pancreatic cancers: exocrine and it's endocrine. So exocrine, again, there's glandular tissues. They're going to be ductal adenocarcinomas, and these are the most common. These are 90% of all tumors, and these arise from the ductal epithelium of the pancreas, typically around the head of the pancreas. And then you've got your pancreatic neuroendocrine tumors, and these are 5 to 10% of pancreatic cancers. You've got your endocrine cells, your Langerhans, so these are involved with your insulin regulation and your glucagon regulation, so your alpha and beta cells. And And these can be also further classified into insulomas or gluconomas, like I said, with your insulin and your glucagon. Risk factors, just being a nice person is maybe one of them. But like, again, age, obesity, diabetes status, smoking as usual, chronic pancreatitis, interesting enough, and then also a family history. All going to be big risk factors for this disease. So presentation, this can be broken down into the pancreatic head tumors and pancreatic body and tail. So similar with the esophageal cancers, you can be broken down to late and early signs. This is splitting it up by where the anatomy of the pancreas is. So if it's more towards the head, it's going to be more towards the duodenum. It's going to be more towards the bile duct. It's going to be more towards the liver and the stomach as well. And we're going to see maybe a painless jaundice. This is going to be because this cancer is obstructing the bile duct. This might be accompanied by dark urine, pale stools, pruritus, that itching you'll see the patient's complaining of. And then also abdominal pain, weight loss, anorexia nervosa, Kurosawa sign, so pain in the stomach, essentially. And then the pancreatic body and tail tumor, so this is back pain, weight loss, nausea, staturia, and maybe even new onset diabetes, especially when we're talking about like the insulomas or the gluconomas. But you can really see there's not many signs, and if you can really talk about these signs like painless jaundice, they're all really going to be late signs as well. You really need to be obviously ruling out less terrible things, so gallstones, cholangitis. So your gallstones, you just have your right upper quadrant pain, cholangitis, similar right upper quadrant pain, and maybe fever. Hepatocellular carcinoma, so your liver cancer, you probably be experiencing similar symptoms, but maybe right upper quadrant pain. You might also have bleeding disorders as well. You might have that pain leading forward from all the fibrosis and scarring as well. Primary sclerosing cholangitis is a rare disease that you don't really see often, which is characterized by the sclerosing of the cholangitis of the bile ducts, essentially, and then hepatitis and cirrhosis. So you can see here on the image on the right, this is what one of the tumors of the head of the pancreas looks like. So you've got the liver here. This is the pancreas, and this is the head of the pancreas, and that's a massive tumor right there. And you can see, even though it's really big, this is obviously a really late presentation, and it's not going to bode well for the patient. So this is one of the only tumors that you've got a cancer marker for. So we'll be testing for CA19-9, and that's what you can be testing for your biliary cancers as well. You're doing your liver function test as well, just to see what's going on there, see if the patient's got jaundice and what type of jaundice you'll be seeing it as well. Your FBCs and your coagulation, see if there's any liver damage really, or liver metastases. You're doing abdominal ultrasound because we are quite high up. We do want to rule out any liver metastases. You might be able to see the pancreas, but probably not with the stomach being in the way. And then you can be doing CT contrast. You really need to be imaging these patients and seeing what's going on. And if so, if you think you know what's going on, you can see, and the patient is jaundice, you're going to be wanting to stent this patient, make sure the bile's getting out of the patient, make sure the liver's functioning appropriately. And you're going to be doing that through stenting via ERCP. And then a PET scan as well to see if there's anything going on around in the body. Curative treatment, again, surgery, but this is going to be a massive surgery, and we'll get onto that in a sec. And you will be doing chemotherapy to try and reduce the size of this tumor, and then palliative. This is again in the form of stenting, or I've just spoken about chemotherapy, radiotherapy. So this is a Whipple procedure. If you do see one of these as well, I really recommend you go see one of these. These are really big procedures, 12-hour shifts, really. And they can be curative. Can, probably not. Usually by the time you've got to this stage and this patient's come in, it's too late. But if it is found early enough, we can take away the head of the pancreas, can take away the duodenum, can take away the biliary tree, and we'll just suture the stomach to the jejunum, and then we'll attach the pancreas, or what's left of the pancreas, to the jejunum as well, and then the bile ducts to the jejunum. It's really highly complex surgery. There's a lot of vascularity going on there. There's a lot of lymph nodes. There's a lot of everything going in that central segment of the body. I mean, it is really where all your hormones are coming out and helping your body. And there's also, if you are more fortunate enough, I say fortunate, to have a body or tail pancreas tumor, you can do a distal pancreatectomy. And this, what this involves is you'll have removal of your spleen, or the vasculature to spleen and your body and tail of the pancreas. And these usually do better, these patients. If you had your spleen removal, obviously we know your spleen is really important in terms of regulating or your immune system. Yeah, maybe increased risk of infections, particularly from encapsulated organisms, so your streptococcus pneumonia, your Haemophilus influenzas, and your seromeningitis. Can't pronounce that. But these streptococcus pneumonia, Haemophilus influenzas are also really common infections you'll see with people with COPD. And thank you very much. I think we've got one more poll question. And the poll question is the definitive management for a resectable head of pancreatic cancer. So if you could fill that in, please.
So we have 100% going with BIPA procedure.
Yeah, I mean, it could have been a total pancreatectomy, it could have been a subtotal pancreatectomy, but like we said, the key word here is the head of the pancreas tumor. And we need to do that big old procedure, the Whipple procedure. And that's going to be the gold standard, really, or the standard procedure. You can, other therapies, chemotherapy probably be used to reduce the size of the mass. Total pancreatectomy can be used, but often by the time you get to this stage, the tumors usually spread to other organs, adjacent organs. Primary biliary stenting, this used for metastatic disease or unresectable disease, and then your ultrasound guided biopsy. This just helps, but if you diagnose, it's not a really definitive treatment. Thank you very much.
Thank you, Henry. That was very helpful, and I hope all of you enjoyed it as much as I did. Just a couple final bits now for everyone. So I've just sent the feedback form in the chat. And okay, so the feedback form is in the chat. Don't forget to fill it out for you to receive your certificates and also discount codes to teach me surgery and pass the MRCS. I've also sent the Google form in the chat, and for you to win a chance to win free access to the Geeky Medic surgical flashcards and their OSCE stations, fill this link in along with the unique code. Our next session will cover HBB on the 11th, which is tomorrow at 6:30 p.m. We'd love for you to join us again tomorrow. Make sure to follow us on our social media platforms, the links for which are available in the chat. Through this, you will be able to receive updates on the upcoming sessions via these platforms. We've also posted additional SPs on our learning platform, so definitely check that out. We hope you found today's session helpful. Thank you once again for joining us, and we look forward to seeing you at tomorrow's session.